broadcasting from Miami. Today we have the pleasure of having Rafael Martinez-Perez, MD, a neurosurgeon born in Spain but now in Canada, and he's going to tell us what he's doing up there. And we're also joined by distinguished members of the panel. Let's introduce them first before we turn it over to Rafael. Good day, Francesca.
Good day, everyone. I'm Francesca. I'm a fifth-year medical student from Bucharest, Romania, the president of the Walter Dandy Neurosurgical Club here. And I'm really excited to see Dr. Rafael's presentation because I would like to be a pediatric neurosurgeon when I finish.
Oh, that's fantastic. I didn't know that. Well, we get to meet another one right here, Griselda.
Hello, my name is Griselda Ramirez. I am a pediatric neurosurgeon at Mexico City. Nice to meet you too.
Very, very good. Griselda, we had a great conference in pediatric neurosurgery a couple weekends ago. Okay, Slaven, welcome.
Hello, everyone. My name is Slaven Gojkovic. I'm also a medical student in Zagreb, Croatia. And also a president of Dandy Club in Croatia.
Wow, we've got some pretty impressive people here. Okay, Rafael. Okay, Rafael, it's all yours.
Okay, so hello everybody. I think that the image is already freezing, John. So
okay, that's okay, no problem.
Okay. So hello, I'm Rafael Martinez-Perez. So we are going to talk about today interesting topic for me, which I am endovascular and open vascular neurosurgeon. So we are going to talk about cerebral aneurysm in the pediatric population. So let me show you.
Okay, we'll get it.
It's taking for a while.
Okay.
Can you see now?
Yeah, it's not as good as you had it before.
Okay.
Yeah, perfect.
Okay. So first of all, thank you to Neurosurgical TV to let me to participate in your conference. So as I said before, we are going to talk about the pediatric cerebral aneurysm. This is a very common topic for all type of neurosurgeon, but this type of pathology used to happen in adults, and it's very uncommon, curiously, to see in the pediatric population. Actually, only 1 to 5% of all cerebral aneurysm are found in the pediatrics, and they have some interesting features that in this type of aneurysm that raise our concern to treat this aneurysm in a different manner that we would treat an adult patient with surrounding hemorrhage plus cerebral aneurysm. So these features are that, as an introduction, that 2/3 of the cases are fusiform or dissecting aneurysm, most especially in children younger than 5 years old. And also there is a high prevalence of complex and giant aneurysm. However, of the 60% of all spontaneous surrounding hemorrhage develops a cerebral aneurysm in kids. They have a male predominance in contraposition than in adults, where the female ratio is 4:1 for female. And this predominance in males in kids used to approach to 1:1 when they get older and when they reach the puberty, which can tell us that maybe this is something related with some hormonal or humoral factors. There is a different pathophysiology than in adults, and also we should take into account that there is a much longer term life expectancy. So as we said before, it's not sure which is the difference between kids and adults, but many people think that there's some kind of different path of pathophysiology. So in adults, we used to think that the aneurysm are developed for some kind of hemodynamical stress, mostly happen in the bifurcation of a vessel, where the stress force are much higher than in any other part of the artery. And in this weakest part is where the aneurysm grows up. However, in kids, there is also could be some type of intrinsic vessel condition in the wall that might rise the velocity for growing up of this aneurysm. In fact, these aneurysms are associated more commonly than in adults with polycystic kidney disease and also Ehlers-Danlos disease. So, over the time in kids, we will talk about that later, but we should and we have to follow this patient for a long time, given that even if we treat the current cerebral aneurysm, this patient used to develop over their lifetime, they used to develop other what we call de novo aneurysm. Regards the location, there are also some specific findings. One of them is very typical, or is very common to see even more than in adults if we speak regards proportion of finding some ICA termination aneurysm. This is the aneurysm that we see here in the right ICA termination. This, for sure, we can show this aneurysm in adults, but it's not such as common as in kids. In the arterial circulation, we are going to find MCA aneurysm, and in less proportion, ACA aneurysm. Another finding that it's very interesting is that the proportion of aneurysm located in the posterior circulation is much higher than in adults. So we see 25% of aneurysm located in the posterior circulation as basilar aneurysm, vertebrobasilar junction aneurysm, and also in the PCA and distal PCA aneurysm. Curiously, these aneurysms are more commonly dissecting, and it's also have a worse prognosis once they get ruptured. So we talk about anterior circulation aneurysm and posterior circulation aneurysm. Regards the anterior circulation aneurysm, we also find aneurysm in the middle cerebral artery, also known as MCA, but in adults, they used to occur in the bifurcation of the MCA, but as we see here, we also can find this aneurysm more distally in segment M2, M3, and even M4. They might present in very different manner, but however, it's uncommon to see incidental aneurysm in kids, just only because of the fact that we don't used to perform a CT scan or an MRI in a kids as much frequent as in adults. But they also can present with Sorano hemorrhage, like in the case I present you here. So this is a fusiform dissecting right MCA aneurysm which has been ruptured, and it has Sorano hemorrhage, which is located over the basal sisters, more prominently in the right sylvian fissure, as we see in the image. But they also can present with mass effect and some neurological symptoms. Here is another left MCA aneurysm. This is located in the bifurcation, but this aneurysm is what we call giant aneurysm. It has more than 25 millimeters, and also in this kid presented with some mental delay and It could be also the presentation is a different manner, and they can present without surrounding hemorrhage, and this is another indication for treatment in this subgroup of patients. So in kids, we're gonna find this type of aneurysm. We are gonna find in the left side of the picture, saccular aneurysm as in adults. So these aneurysms are located in the bifurcation where the stress force are bigger. We also can find fusiform aneurysm, where the aneurysm is located here in the side wall of the vessel. So this aneurysm is very difficult to treat endovascularly because it's impossible to reconstruct the parent vessel without occluding actually the vessel. And we also are going to find giant aneurysm, like are those aneurysms which I said that are bigger than 25 millimeters. This is a literature review of the most recent series, and as we see here, there is a high incidence of fusiform aneurysm, which could be as high as 50% in Lascaunia's series, but as we see here, could be 32% in Kalani series. This is quite high fusiform percentage of aneurysm if we compare with the series that we see in adults. And also the saccular aneurysm is in a much lower proportion, which are dominant in adults. We also find huge prevalence of giant aneurysm. Here we see Kalani series, that this is a bypass surgical series. It's about 45% of cases. Mortality depends on the series, but we will see later. So if we talk about the etiology, I mentioned that saccular aneurysm is much more infrequent in kids than in adults, and it's even more infrequent as we go with lower age. So if we see, for example, patient under 2 years old, so we don't see many saccular aneurysm comparing with dissecting aneurysm. But the proportion in kids older than 11 years old is much closer to adult population, with a huge proportion of saccular aneurysm in spite of having some fusiform aneurysm. So in summary, we could say that as younger is the kid, more chances of found a fusiform aneurysm. So this is another way to say, so saccular aneurysm are found more prominently in kids older than 5 years old. In the anterior circulation, they used to have a better prognosis in comparison with fusiform aneurysm once they are ruptured. If the saccular aneurysm is small and is not complex, it doesn't have any branch coming out from the dome or the neck of the aneurysm, they are amenable for direct treatment either as clipping or coiling. However, this treatment could be much more controversial if we refer to the fusiform aneurysm, which is very prevalent in kids younger than 5 years old. And they are also even more prevalent when this kid has an aneurysm in the posterior circulation. So here I show you a typical radiological finding that we see in fusiform aneurysm. In the left side of the image, we see the red arrow is pointing a partially thrombosed aneurysm. Actually, could be could be understood as a mass effect, given it's compressing the left dorsal part of the mesencephalon. In the left part, with the three, this is a sequence called POF. It's for better depicting how the vessel goes into the brain. And we see here where the other red arrow in the red picture, it's showing a small piece of stenosis right before the cerebral aneurysm. This is a very common presentation in the fusiform aneurysm. And if we see further, the cerebral aneurysm is partially thrombosed and it's getting less flow than expected, and it's very difficult to see in the same branch, more distally, flow in the left calcarine PCA. So this sign is called peel and strain sign, and as I said, it's very common in fusiform aneurysm. We're going to talk more about the course or the typical course of the fusiform aneurysm. In the previous picture, we saw that these aneurysms are associated with previous dilation or stenosis of the vessel. These stenosis tell us two things. These stenosis, tell us two things. One thing is that maybe this vessel, it's already damaged and it's more prone to suffer the growing of an aneurysm. And also it's telling us that this stenosis probably will produce in the future some spontaneous thrombosis or spontaneous healing of the aneurysm that for sure is gonna occlude the vessel distally. So once we have a parent vessel that is occluded, we could think that could be some type of ischemia more distally. But what we see in children, mostly when they are younger than 4 or 5 years old, is that they have very good, tremendous leptomeningeal collaterals coming from the external carotid artery, but they have, or from other branch from the internal cerebral artery, but they tolerate very well this spontaneous thrombose without developing neurological impairment. The problem of this aneurysm is that they also are very prone to suffer surrounding hemorrhage. For that, there is this aneurysm. It's worth to treat them in terms to avoid the risk of having a surrounding hemorrhage and neurological impairment in the future. But this fusiform aneurysm, as I said, they have very worse prognosis. They have worse prognosis in comparison to saccular aneurysm if they are ruptured. And once they get ruptured and they suffer a surrounding hemorrhage, the patient might suffer rebleeding. This is very common in the first 48 hours, and also all the possibility after between the 2nd and the 14 days, there is a high risk of having vasospasm. This vasospasm is an important concern in the management of surrounding hemorrhage in adults. However, in kids, it also happens in a similar frequency, but curiously, the patient do clinically better. And it seems that it's also because this patient used to have better leptomeningeal collaterals. And that's why it's very, well, it's not well tolerated, but maybe better tolerated than. So here I show you another imaging from the previous picture, and as you see here, we see the previous aneurysm that in the first imaging in the MRI, it seems that it has an stenosis right after the black arrow. And when the patient was took to the cerebral angiogram suite, we see where we have the left red arrow that there is a complete occlusion of the vessel. So it seems that has been a spontaneous heal. This also, as I said, could be concerning because the patient can develop some kind of neurological deficit, but this was not the case of this patient. So, however, there is some reports that in spite of having a spontaneous healing, this patient used to develop some de novo aneurysm that could be far from the previous aneurysm or could be so close. So that's why it's very important to even after having a cerebral angiogram where there is no any more cerebral there is no more any aneurysm, we should follow up this patient very closely. We're going to take a look also about a specific type of aneurysm, what is called infectious or mycotic aneurysm. Curiously, this aneurysm we call mycotic aneurysm, but this aneurysm used to refer to aneurysms which are infectious, but they are not commonly produced by fungus, but they are produced by viral or bacterial infection. This aneurysm used to be fusiform and used to happen with frequently in children. So we have two etiologies. First one is the bacterial etiology, and they used to grow up in very distal circulation, like as I said before, in an M4 or in a very distal branch of the PCA. They have a fusiform shape, and they could be managed well with conservative treatment and with antibiotics. However, we should take care with patients which are infected by virals and they develop some fusiform aneurysm, because this aneurysm used to be located in the proximal circulation, in the ICA, for example, and also in the proximal part of the middle cerebral artery. This aneurysm required further treatment because the risk, we saw that the risk of having a hemorrhage in this type of aneurysm is much higher, and the complication associated to the surrounding hemorrhage could be devastating for this patient. So I forgot to say, but in bacterial origin, it's very important to do an echocardiogram just to be sure that there is no vegetation on the heart. And the most common etiology in the viral etiology is the HIV. So we're going to see which are. So we always in neurosurgery, we have some challenge, and we also try to give our patient the best available option for the treatment. So which are the challenge in the treatment or cerebral aneurysm? So we have to remind that there is a high incidence of giant and complex aneurysm, which makes this more difficult or less amenable for endovascular treatment. We consider complex aneurysm those aneurysm which has a branch that is coming from the dome or from the neck. In this case, endovascular occlusion has higher risk of having an occlusion of a vessel coming from the dome. Also, in giant aneurysm, we see, and there is a very well-known fact that one potential risk factor for recurrency in aneurysm that has been coiled is the size and the aneurysm. So this aneurysm is it's our opinion that the treatment in this type of aneurysm is not very good or is not very well accomplished with endovascular therapy. Also, we talk a lot about fusiform aneurysm, which I said they are very incident in pediatric population. We also talk about the distal location, which is another challenge for endovascular therapy. And also another factor of recurrency of recanalization of the aneurysm that has been coiled is the time of follow-up. These children probably will have at least 70, 80 years more of follow-up. And in this case, it's very common to see some kind of recanalization that in some series in adults goes as high as 90%. So when we talk about treatment, we are going to talk about endovascular or open surgery, right? And in both, we can talk about deconstructive technique or non-deconstructive techniques. So if we talk about endovascular procedure, we have balloon occlusion, we can treat the patient with coils, stent, or even flow diversion. While in surgery, we have trapping, occlusion, plus/less bypass, clipping, and wrapping. So there is some series in children population treated with endovascular treatment, either with coils or flow diversion, which shows acceptable result, perioperative results in terms of morbidity and mortality. In fact, they could have, in the perioperative result, they could have lower morbidity than in surgery. However, these studies, in my point of view, they lack of a very long follow-up in this type of patients. So we are missing those patients that are going to recanalize in 10, 15, or 20 years, or these patients who are going to suffer a de novo aneurysm. It's also, as I said, a challenge for treating the jejunal and fusiform aneurysm. So here in the image, we have a complex aneurysm that has been treated with coils, with stent. We see in the middle pictures, we have the coils inside the aneurysm, and also coming from the internal cerebral artery to the middle cerebral artery, there is a stent. And also there is a balloon that also would help for packing the coils. We see the problem of this aneurysm is that the MCA, it's incorporated to the neck of the aneurysm. And actually, in fact, as we see in the middle of the image, there is a loop of the coil that is getting into the middle cerebral artery. And also there is an associated, since that very small minimus thrombus in at the base of the coil mass. So could be a good result. And actually, I think this is one of the best results that we can achieve with endovascular therapy. But this is not definitive. This patient requires a very long term of follow-up. And for sure, endovascular is an option, but I think we should think more about, or at least neurosurgeon, we should be more prone about open surgical treatment in this type of aneurysm. So, as I say, we have coiling. Problem with coiling is incomplete occlusion of the aneurysm, which rise our concerns of recanalization. They also have thromboembolic complication, and they could migrate, occlude the parent vessel, and produce an occlusion of the parent vessel. And they also have a challenge that I did not mention before, which is there is a huge proportion of these aneurysms that are located more distally Furthermore, these kids, mostly when these kids has less than 2 years old, has a very small diameter of the vessel, which makes very hard, very tough to get with the microcatheter so distally to be able to get into the aneurysm and occlude it. So this is also could be a challenge from endovascular treatment, which could be the best, maybe the best candidate for endovascular treatment. So it could be that kid that has that is older than 10 years old, or those guys who has a saccular aneurysm with a very small neck. I think this patient it's could be very well treated with coiling. Otherwise, fusiform aneurysm, giant aneurysm, complex aneurysm, we should think other alternative, which could be surgery or combined endovascular and open surgery. This is another case of the left MCA giant cerebral aneurysm. Besides all the challenges I mentioned before, one of the most prominent important risk factor for recanalization is size of the aneurysm. This aneurysm is 30 millimeters. And other factor, and maybe this is very related to the size of the aneurysm, is the packing of the aneurysm, which is the percentage of coils of coil mass in comparison to the volume of the aneurysm. So if the aneurysm is bigger, it's difficult to get a better packing. And the next problem that I found in this case is not only recanalization, but also we do not resolve the trouble with the mass effect. And also, in fact, if this aneurysm recanalize or have any recanalization, it also might produce, if the patient hasn't developed any mass effect before, it could produce a mass effect later. So flow diversion is another option for the treatment of this patient. The experience with flow diversion has not been very well reported. And a problem that I find with this type of patient is that you do not occlude the aneurysm at the first attempt, so that the aneurysm is occluded over the time. So we need to put the flow diversion, we need to deploy the pipeline or any other flow diverter, and then we have to start the patient on antiplatelets, which if the patient has an acute hemorrhage, the chances of having a rehemorrhage of that aneurysm that is completely occluded are much higher. However, in adults, the PATH trial seems to have only 5% of intracranial hemorrhage, and this is not related with the aneurysm, but with thromboembolic complication related to the flow diversion. But it seems that these results are not such as good as in adults, and also, as I mentioned before, there is not long case series to report the complication or the succeed of treatment of this patient with this flow diversion. So we already talked about endovascular available option. We are going to focus now on the surgery management. So in surgery, we said that fusiform has a worse prognosis if they are ruptured. So surgery allows us a direct vision of the aneurysm. And once we see the aneurysm directly in the surgical film, there are some options. It could be direct clipping, which could be equivalent for more simple aneurysm, saccular aneurysm. There could be saccular aneurysm or small aneurysm. could be wrapping, or could be parent-vessel occlusion, trapping, or use or not of bypass to assure distal revascularization. So we could use bypass. We are going to focus now in revascularization techniques. We have one here. It's this is an article from the SECAR group, from the group of Shadow. So if possible to do a bypass just intracranially directly, like we see in the right upper part of the image, where we have a radial arterial graft which connect the proximal and the distal vessel after dissecting and remove the cerebral aneurysm. Other option is to do an extra intracranial bypass, which is, as I will show you next, we'll talk more about later. But when to do a bypass it's in adults, for example, what we do to assure that the patient is gonna tolerate parent vessel occlusion, what we do is we do a balloon test occlusion. This is very difficult to do in kids because it's very difficult to monitorize either clinically or with EEG. And also most of these patients has an acute onset of Schwannoma hemorrhage, which make very difficult to break the patient, to awake the patient and do a balloon test occlusion. So if we question if the patient should have or not some kind of revascularization, or we are gonna occlude the parent vessel in order to treat the cerebral aneurysm, I think it could be worth it at least to try some type of bypass revascularization techniques. It could be a low flow, extra intracranial bypass, or a high flow. We always prefer to treat this patient with high flow bypass because it gives us larger areas of perfusion, and also the donor vessel is of greater diameter, and this is also a challenge in very small children, which always we can to use a high flow bypass. It could be worth it to try, and try to give as much flow as we can to the ischemia zone. So it's also, we always try, if the patient is in the vasospasm period, or we see in the MRI or in the angiogram that there is considerable vasospasm, we always try to wait and see until the patient is in a better shape in terms of vasospasm. And we always look for a donor vessel that could be at least 2 millimeters in diameter. So that's why we sometimes need in very small children to use high flow bypass. Curiously, this bypass, it doesn't work out as in the Moyamoya disease or in adults, where the leptomeningeal circulation, in adult leptomeningeal circulation start to work after a short period of time. So there is a high incidence then of reocclusion rate of the graft. In the series of bypass in children, this occlusion rate is lower, and and also the rate of thrombose of the graft is also lower. So this occlusion is produced in the early stage by some kind of thrombose within the vessel that could be avoided with a perfect surgical technique. Also charge the patient in antiplatelets in order to avoid any type of thrombose or occlusion. So as we see, as I said before, in this type of bypass, there is no leptomeningeal recruitment, which make this graft less prone to have a reocclusion. So this is a type of bypass. This is an intracranial bypass. So we see in the left part of the image, we have a fusiform aneurysm, which it seems that it doesn't come out any branch from it. So the authors treat this case just with, in the right part, we see the final result, just removing the cerebral aneurysm and doing a radial arterial graft bypass. This is another example of intracranial bypass, where in the left part of the image we have another fusiform aneurysm in the middle cerebral artery, which was treated with resection and intracranial bypass with an arterial graft. And this is another example, but this is an extracranial intracranial bypass from internal cerebral artery to middle cerebral artery in the M2. So here we see in the right part of the image, there is no any more filling of the aneurysm, and there is correct filling of the distal branches, distal to the bifurcation, M2, M3, and M4. So some topics about pediatric revascularization in bypass. As I said before, we always try to use graft instead of low flow bypass, given that it's give us a greater in diameter recipient vessel in the intracranial artery. And it also gives us the chance of having lower rates of occlusion. So in terms of which graft we should use, we don't have any experience with arterial graft for extracranial, intracranial bypass. But with a venous graft, or as a venous graft, it seems to have very good results with very low morbidity and mortality. And as I said before, the occlusion rate with a saphenous graft in children, it seems to be much lower than in adults. And also other problem that we might think in this case is what happened once our children of, our pet of 2 years old grows up and he has 180 centimeters, 15 years old guy. What happened with that saphenous graft? Well, there are not too many case reports regarding this, but there is no, it seems that also the saphenous graft used to expand or grow at the same time the patient is growing up. We mentioned at the very beginning that the pathophysiology of this aneurysm in children seems to have any type of impairment of the vessel wall that make this patient more prone to develop further cerebral aneurysm, either distally or very close to the cerebral aneurysm. That's why it's very important to follow up this patient, because they could develop some de novo aneurysm, and also if they have any fusiform aneurysm, that has been spontaneously occluded, it's really worth it to follow them up in order to assess that there is no any recanalization and then any risk of having further Sorano hemorrhage. So what we do then? What's our plan? Which is after all this mess, how we can sum up? So we have saccular aneurysm or fusiform aneurysm. In saccular aneurysm, we could say simple, those which could classify as being smaller than 25 millimeters, and those who hasn't have branch coming from the dome or from the neck of the aneurysm. As I said, saccular simple aneurysm are very rare to find in pediatric population. It's more common to find giant or complex aneurysm, which could have some mass effect or Sorano hemorrhage. We also have fusiform aneurysm, which are very frequent in pediatric population, especially in kids younger than 5 years old. And this fusiform aneurysm could be located in an extensive location or could be very focal. Those who are located in an extensive location are recognized because it doesn't show up any hematoma on the wall. They used to happen in younger children. They used to be associated with Sorano hemorrhage and rupture, and they used to recurrence very early. However, focal fusiform aneurysm, we are going to find a lot of focal aneurysm with we can show the sign that is called mural hematoma, which shows a double lumen. This is very common to see in teenagers. They used to have an ischemic presentation and they used to trend to an spontaneous healing. So let's back to the saccular simple aneurysm. This aneurysm, as we say, they are more prone to treat with direct techniques such as clipping or coiling. If we have a fusiform extensive aneurysm or a giant or complex aneurysm, I think it would be worth it to do some kind of surgical technique and, if possible, assess distal vascularization with bypass. It also for sure could be combined with endovascular technique. Could be some patient, instead of looking for an occlusion or anterior ligation with open cranial surgery, could be occluded with an endovascular technique, like with a balloon, and then assess distal flow with a bypass. All these options, I think, are acceptable. And in this type of fusiform focal aneurysm, which appears in teenagers, we could try, because the rate of Sorano hemorrhage is much lower, we could try to look for conservative treatment and the follow-up in this case, assess the spontaneous occlusion, and for sure follow-up for a long, long time. Because this patient, even if we don't need any treatment for them, it's our opinion this patient should be follow-up for a long period of time. And so this focal aneurysm, as we said, could be found distally, and if we think there is any bacterial origin, they should be treated with antibiotics. However, I would say that 60 to 70% of aneurysm that occurs in children, they used to be or giant complex aneurysm or fusiform extensive aneurysm, which require further surgical treatment. And that's all. Thank you so much. And that's our presentation.
Okay, excellent. Excellent, Rafael. The content was superb, and your presentation worked out well with this platform. Now, to get off the Hangout, Richard, Rafael, just click on the green arrow.
All right.
There we go. Well, unfortunately, we're not seeing your face. There's a technical problem. But let's start the question off with Griselda. Griselda, you have anything to ask Rafael or comment?
Congratulations. It's very interesting camp. We had a small experience with patient with aneurysm, but it's more common observed arteriovenous malformation in my hospital. Thank you very much.
Thank you. Yeah, I appreciate you tell us. I think your experience is good. Yeah, for sure. It's much more common to see some kind of AVM rather than a cerebral aneurysm. If we see any cerebral aneurysm, they could be related also to the AVM. Could be some flow-related aneurysm to the AVM, which also they have high risk of hemorrhage and rupture, rather than because of the AVM. But thank you.
Okay, very good. Any other questions, comments from the other students?
Oh, yes.
Hello. Yes.
Hello.
Go ahead.
Yeah.
Hello, Abdullah. Could you introduce yourself, please?
Yes, I'm Abdullah Said. I'm an Egyptian student, a medical student. I'm studying my first year. I'm studying in Bucharest, Romania.
Okay, excuse me just for a second, Abdullah. Somebody has two programs open. Please close all your programs other than the Hangout. Okay, that'll stop the reverb. Rafael, I think you may have something else open beside the Hangout.
Really? That's my phone?
Yeah. I think we're getting feedback from another source. Yeah.
Let me see.
Well, I could always blame Slaven.
So what else should I do? All right.
Oh yeah, just exit everything except your Hangout.
All right.
Okay, there we go. Whoops, we still got it. Abdullah, do you have two programs open?
No, I think he doesn't have. He has the speakers on.
I'm sorry?
I think he had the speakers on, and he doesn't have anything plugged in. So
Okay,
when we
there it is.
talk, then
No,
you
it's
can
gone.
hear yourself again.
It's gone. It came from Rafael because he's gone, but he'll come back. Nice to have you, Abdullah, and Garab back again.
Yeah, it's my pleasure, sir.
Hey, you heard I guess IPE is opening a lot of neurosurgical beds in Nepal. Okay, well, here's Rafael's back.
Yeah,
Okay.
yes.
I'm back.
Okay, Abdullah, go ahead. Abdullah,
Yes.
I believe, had a comment or question, Rafael.
Yes. First of all, very, very nice presentation. Very clean and sleek. Yeah, it was very classy actually, and I enjoyed the presentation. Unfortunately, I didn't catch up from the beginning, but I have a question about, you talked about bypass. I was wondering if you can perform complete obliteration in case of children, complete obliteration using a flow diverter or something like that. And if it's possible, would the morbidity rates would be higher or lower compared to the bypass?
That's a very interesting question. Thank you, Abdullah. The problem that I find with the flow diverter is lack of experience so far in children, and they also require do an antiplatelet therapy to assure that the that the bypass, that the flow diverter is not, it doesn't occlude it. At the same time, you cannot reach a direct aneurysm occlusion. That's very weird to find a direct occlusion of the aneurysm. But in fact, as you say, it's possible to treat. My answer has to be yes. And also, there are some interesting series about that. But the problem that I find with flow diverter is that you need dual antiplatelet in a patient who has an active subarachnoid hemorrhage and also who has an aneurysm that is not secure enough. That's how we believe. If we compare bypass to flow diverter, I cannot give you any answer because there is no comparable series between them, and I think it wouldn't be fair to give you an answer which is better in regards to the literature that it's already written.
Okay, very good. Any other questions or comments? By the way, Abdullah is quite a prolific video person on the internet. So when he gives you credit for a good presentation, he knows what he's talking about.
Thank you.
Okay, we have another student from Nepal. I don't think you met him, Rafael. Hello, Gaurav. Do you have any questions or comments for Rafael?
Yeah, first of all, I'd like to start from the comment. And the presentation was, as smart as you look, okay, Dr. Rafael.
Thank you.
And though I missed the first beginning part, and I happened to find one line. You said that grafting, we prefer grafting to low blood flow, right? You told that way, I guess.
Oh.
So what does that mean actually?
Okay. Yeah. I'm sorry. Maybe. So when I say graft, so we use graft for high flow bypass. So we have high flow and low flow bypass. As the word says, high flow is when you want to give more flow and when you want to cover larger areas of ischemia. And low flow, it's more simple technically, but it doesn't give you such as good cover for the ischemia zone. That's the difference.
Okay.
But if we do grafting, then wouldn't it give the same blood flow as it would give when it was normal?
Sorry, pardon, repeat again.
And I just wanted to say that if we do grafting, wouldn't it give the same blood flow as it would give when it was normal?
Do you mean if could be possible to use graft or low flow diversion? You mean that, or?
Yeah. I just wanted to say that grafting means just you got the one which is less useful and put next one, right?
Yeah. Well, grafting is to take a graft from the radial artery or from the saphenous vein, right? So you can take that vessel and you can bypass from internal cerebral artery or ECA or even common to middle cerebral artery, the proximal part of the middle cerebral artery, or to the PCA, whatever. That's what I mean by graft. Also, you can use graft, as you say, to connect intracranially from a more proximal part to a more distal part for bypass a vessel that it's already sick, like an aneurysm or a fusiform aneurysm.
Okay, very good. Thank you. I think we're a little short on time. Francesca, do you have a question or comment?
Yes, first of all, thank you for this incredible presentation. I actually understood everything.
Oh,
that's new for me. And I do have a question. I remember Professor Abdul Rauf once showed us a case of recurrence of an aneurysm after coiling. Have you seen this kind of cases in the pediatric population? I think it's more difficult to clip them or to treatment after they were already coiled.
Oh, yeah, that's very interesting. Well, whatever says Dr. Alvarado is clear. So it's a very neurosurgeon. So yeah, it's very difficult to manage them because once they are coiled, the aneurysm is heavier, and also it's very difficult to mobilize, and that's why it's more difficult when you have all the mass of the cords. That I don't know is that what you mean. If you said if we see any recanalization in this type of children, the answer is no, because we haven't treated. We don't use to treat aneurysm in children with coils, but recanalization it's a very common presentation in the follow-up in the aneurysm that has been coiled.
Very good. Okay, I'm sorry to end the presentation. I'm sure Slaven had a couple of questions, but we can always have more hangouts. We have another one in Spanish now, so I'll send the links to anyone who's interested. Okay, Rafael?
Yeah, sure. Thank you so much.
I'll send you another link. And so, okay, students, say goodbye to Rafael.
Goodbye.
Yeah,
Okay.
goodbye. Rafael. It was nice
Goodbye.
to meet you, okay?
Okay, Rafael, I'll send everyone a link, another link. We're closing here. Thank you very much.
Thank you so much.
Thank you, Dr. Bennett. Thank you.
Thank you.